practice, and we were not doing thoracic oncology any time. We were basically in cardiothoracic, pure plain adult cardiac and thoracic surgeries. This patient is a 16-year female studying in 10th class and suddenly presented with breathlessness, chest pain and cough to a pulmonologist. Investigations revealed that she had a left pneumothorax with a ruptured cyst in the left lung. Initially, they put a left intercostal drainage tube and was placed, but the BPF was not closing. Then they referred to us why it was not closing. Then hence we investigated further for surgical management of the patient. Then we could found a collapsed gross pneumothorax on the left side, and there is a cyst on the upper lobe of the left lung. And then we have done a bronchoscopy. If any problem is there from the broncho, but it was looking normal. It was just a rupture of a cyst or a bulla. Then we planned for an operative procedure. Left posterolateral thoracotomy was done, and excision of cyst was done, and closure of bronchopleural fistula was done. Then this cyst was sent for histopathological examination. On the second postoperative day, lung expanded completely with minimal ICD drain, and the ICD was removed on the second day, and the patient was discharged on the sixth day. We have done this patient in government scheme, free of cost. Then, but we sent the patient for the histopathological examination, which was showing tumor was composed of spindle cells arranged in irregular fascicles. The tumors were interposed with microvasculature with foci of hemorrhage mitosis, which was partially seen. There was no evidence of any necrosis, ATP or malignancy. They were given an impression of suggestive solitary fibrous tumor and advised for IAC for confirmation. In the meantime, we tried to contact the patient after 2 weeks. When the histopathology has come, patient was not responding, and we lost the contact of the patient. But again, after 6 months, she presented herself in the casualty with breathlessness, chest pain and cough. Then what we have found is she was evaluated again and found a huge mass in the superior mediastinum. A CT scan was done, showing a large, well-defined lobulated hypodense lesion, mass approximately 12.1 into 7.6 into 8.5 centimeters in the superior mediastinum on the left side, a well-defined, elongated, enhancing heterogeneous lesion was approximately 7.4 into 2.8 into 9.7 centimeters was noted in the left pleural cavity extending from 9th, 10th and 11th ribs. So they have given an impression of thymoma with a pleural deposit or metastasis. Then we did an ultrasound guided needle biopsy, which revealed the lesion was composed of spindle cells arranged in the form of fascicles and sheets suspicious of synovial tumor. Then patient was having congestion, breathlessness on rest, so immediately we planned for decongesting the patient and did a left posterolateral thoracotomy again, and we were planning to excise the mass as it was solitary fibrous tumor. So other preoperative blood and image investigations were done, which were within normal limits. We scanned the brain, we scanned the abdomen, everything was normal. But on intraoperative finding, the lesion was a mediastinal mass arising from the medial part of the pericardial and major vascular channels, including aorta, pulmonary vessels, left upper lobe and posterolateral part of the chest wall. The posterolateral part of the chest wall we could remove completely, and we can send it for histopathological examination. The medial part of the mediastinal mass was tightly adherent with the pericardial structures and aorta. So we had left in situ. We consulted the oncologist here at this juncture, even oncosurgeon. Then we has left in situ after debulking the area anteriorly and superiorly, removing the compression on the heart and the blood vessels. The radiation marker clips were kept all around the tumor. So this was the intraoperative photos which were showing that there was like a frozen chest, the mass was everywhere, over and anterior and the superior part of the chest, lungs, and we removed all the, we demarked the areas. The intraoperative picture showed the that this was after removing of the chest wall. This was after removing of the tumor, and this was the mass which was there. Postoperatively, again patient was discharged unevenly, but this time we did a histopathological examination which showed that again this was looking like like it has bundles of spindle cells with elongated nuclei and granular chromatin and inconspicuous nucleoli with scanty amount of cytoplasms, and focal area of necrosis admixed with stagon-shaped vascular channels resembling hemiperiangiocytomas vessels were seen. Area of hemorrhage, fibrous and fibrin was seen. This was Immediately we went into immunohistochemistry where it showed pan-CK was positive for lesional cells, TLE and EMA were similarly positive. So they gave a diagnosis of monophasic synovial sarcoma of spindle cell type. So the patient was sent for oncology and had 3 cycles of chemotherapy with a growth stimulating factor and waiting for the 4th cycle. Radiotherapy was to be planned to be done again. Then patient has undergone 3 cycles chemotherapy with adriamycin, ipsomide and pegstrel, that is growth stimulating factor. The X-ray showed after 3 cycles of chemotherapy nearly 90% of the clearance. Coming to the discussion part, primary pulmonary sarcoma is a rare soft tissue malignancy presenting 0.1 to 0.5% of all the primary lung tumors. Our issues were the recognition of this tumor in an unexpected site such as pleura is often difficult, and monophasic variety of synovial sarcoma is often mistaken with other spindle cell tumors. Like